Assalamualaikum and good day. Welcome to my fourth lecture of the Asynchronous Learning in GMT 106 Haemopoietic and Lymphoid System course. The lecture is on white blood cells and its benign disorders. My name is Dr. Farid from Department of Hematology. My email address is down there. Do contact me. I'll be happy to take all your questions. So in this lecture, you're going to learn about differential counts, granulocytes, mononuclear cells, quantitative leukocyte disorders, and qualitative leukocyte disorders. So what are these white blood cells? They are leukocytes grouped into granulocytes and agranulocytes. So granulocytes are named according to their staining characteristics in blood films, includes three types of leukocyte cells, the neutrophils, eosinophils, and basophils. Leukocytes may also be divided into the phagocytes and the immunocytes. Granulocytes and monocytes comprise the phagocytes, while lymphocytes are the immunologically competent cells that assist phagocytes in body defense against infection and invasion. So these are the white blood cells seen under the microscope in normal individuals. So this one in the middle is a neutrophil. Neutrophil has lobes nuclei. The top right corner is an eosinophil characterized by the coarse cytoplasmic granules. At the bottom right is a basophil, is characterized by a dark cytoplasmic granules overlying the nucleus. Bottom left is a monocytes, the largest leukocytes, and lymphocytes, the smallest leukocytes. Now, the differential counts. The leukocytes differential counts determines the number of each type of white blood cells present in the blood. It can be expressed as a percentage, which is a relative numbers of each type of white blood cells in relation to the total white blood cells, or as an absolute value, which is a total white blood cells times percentage. The absolute values gives the actual number of each white blood cells in every millimeter cubic of blood. So this is a list of white blood cells showing the relative counts and absolute counts in the peripheral blood of normal individuals. So the total white blood cells is between 4 to 11 times 10 power of 9 per liter. Neutrophils, which is the most abundant white blood cells, the relative count is between 50 to 70%, and the absolute count is between 2.5 to 7.5 times 10 to the power of 9 per liter. Eosinophils, between 0 to 5%, and the absolute count is 0.04 to 0.44. Basophils, which is the least number of white blood cells, less than 3% relative count, absolute count between 0.01 to 0.1. Lymphocytes, 25 to 35%. The absolute count is between 1.5 to 3.5. And monocytes, the relative count is 3 to 10%, where the absolute count is between 0.2 to 0.8 times 10 power of 9 per liter. Now, we start with the granulocytes. Again, granulocytes are the neutrophils, eosinophils, and basophils. They are called granulocytes because appearance of granules in the cytoplasm. Compare the fine granules in neutrophils and coarse granules in eosinophils and basophils. These granules take up stain differently and can be seen by different color here. So look also at the nucleus. All three have lobes nucleus. So now, neutrophils. So under the light microscope, 2 to 5 lobes of dense nucleus are visible. 1, 2, 3. 1, 2, 3, 4, 5 here. So the cytoplasmic of neutrophils is pale with irregular outlines, means it is not too round and not smooth. So there are many azurophilic granules which is the primary and secondary granules. Remember from the first lecture, the primary granules are produced during promyelocytes, while the secondary granules in the myelocyte stage. So the contents of primary granules are the myeloperoxidase, acid phosphatase, and hydrolases, while the secondary granules are or the specific granules, the contents are collagenase, lactoferrin, and lysozyme. The lifespan in blood of neutrophils is around 6 to 10 hours only. So neutrophils are the most common leukocytes and serve as the primary defense against infection. The number of neutrophils in the blood can increase in response to bacterial infections or inflammatory disease and various bone marrow disorders such as chronic myeloid leukemia. And neutrophils can also decrease in number of cells in the blood as a result of severe infections and in response to various medications such as chemotherapy. Now, eosinophils. Eosinophil has bilobed nucleus, 1 and 2 lobes there, and very rarely more than 3 lobes. Eosinophils has coarse granules, which are more deeply red stained compared to neutrophils. The functions of eosinophils, they are active during allergic responses, defense against parasites, removal of fibrin formed during inflammation. The number of eosinophils in the blood circulation may increase or decrease. An increase in eosinophil counts are associated with allergic reactions, parasite infections, chronic skin infections, and cancers, while decrease in eosinophil counts are associated with stress, steroid exposure, and anything that may suppress white blood cell production. Basophils. These types of white blood cells are occasionally seen, less than 3% in normal counts. They have many dark cytoplasmic granules, and granules appear as overlying the nucleus. These granules contain heparin and histamine. Basophils migrate to tissues and become mast cells, and the cells have immunoglobulin E attachment sites and their degranulations associated with histamine release. Elevations in basophil counts are associated with cancers, allergic reactions, infections, and radiation exposure, while the diminished basophil counts are associated with stress reactions, allergic reactions, hyperthyroidism, prolonged steroid exposure. Another type of leukocytes are the mononuclear cells. They are called mononuclear cells because their nuclei appear as single with no lobes. These cells are the monocytes and the lymphocytes. Monocytes are the largest white blood cells, while lymphocytes are the smallest. Look at the size comparison between lymphocytes and red blood cells, not that much different. These mononuclear cells are also called agranulocytes because the disappearance of granules in the cytoplasm. So we start with monocytes, which is the largest leukocytes. The nucleus is slightly indented with clump chromatin. The cytoplasm is abundant, sky blue in color, and contains many fine vacuoles. Lifespan of monocytes in blood is between 20 to 40 hours, 20 to 40 hours, and the monocytes leave the blood circulation to enter tissues and they mature in the tissues. Increased monocyte counts are associated with recovery from an acute infection, viral illness, parasitic infections, collagen disease, and cancers, while decreased monocyte counts are associated with HIV infection, rheumatoid arthritis, steroid exposure, and cancers. Now, the lymphocytes. These are the smallest white blood cells. They have large, round, condensed nucleus with a scanty bluish cytoplasm. And increased numbers of lymphocytes are seen in most viral infections, bacterial infections, cancers, and Graves' disease, while decreased numbers of lymphocytes are seen in steroid exposure, cancers, immunodeficiency, renal failure, and lupus. Now, the second part of the lecture will discuss the disorders of leukocytes. So, the disorders of leukocytes can be classified into two groups: the malignant disorders of leukocytes and non-malignant alterations of leukocytes. The malignant disorders of leukocytes are the results from autonomous proliferation of a clone of abnormal leukocytes, while the non-malignant or the benign alterations of leukocytes represents a reaction to underlying non-malignant condition. The malignant disorders includes leukemias, MPDs, myeloproliferative disorders, lymphoproliferative disorders, and myelodysplastic syndromes. The benign disorders can be subclassified into two: the quantitative disorders and the qualitative disorders. Quantitative disorders describes the number of cells, while in qualitative disorders describes the morphology or functional abnormalities. So in qualitative disorders, we look at the changes in size and shapes and also function of the cells. So we start with quantitative disorders. Quantitative disorders are conditions associated with either an increase above normal or a decrease below normal in the number of one or more types of leukocytes in the peripheral blood. An increase in number of circulating leukocytes above the upper level of normal is called leukocytosis, while leukopenia is when the total leukocytes counts below the lower limit of normal. So leukopenia happens when total leukocytes is below 4 times 10 of power of 9 per liter, And leukocytosis is when the total leukocytes is above 11 times 10 power of 9 per liter. Quantitative disorders are the description of number of cells. When the number of cells are higher than normal, we add a suffix cytosis or philia. When the number of cells are lower than normal counts, we add the suffix pinia. So any white blood cells in the peripheral blood can be affected in quantitative disorders. If the total number of white blood cells are affected, they are termed as leukocytosis, denotes high in number, and leukopenia if low in number. If it involves neutrophils, then it is called neutrophilia if high in number, and neutropenia if low. If it involves lymphocytes, then it is termed lymphocytosis and lymphocytopenia, and also eosinophilia, monocytosis, and basophilia, and so on. So, leukocytosis is an increase in the circulating leukocytes to over the upper limit of normal. This is over 11 times 10 power of 9 per liter. It may be physiologic or pathologic. Physiologic, such as stress, exercise, and epinephrine, while pathologic is due to disease or tissue damage. Any one or more leukocytes can be responsible. More often is due to increase in the circulating neutrophils. Neutrophilia or neutrophilic leukocytosis is an increase in circulating neutrophils above the expected in a healthy individual. This represents an increase in the neutrophil counts above 7.5 times 10 power of 9 per liter, and is one of the most frequently observed changes in full blood count. Causes of neutrophilia includes primary marrow disorders and also secondary to a disease process. So this is a slide of a peripheral blood of neutrophilia showing neutrophils with a segmented nuclei surrounded by erythrocytes. The intracellular granules are visible in the cytoplasm, and normally you won't see this many neutrophils in one view under light microscope. Neutrophilia can be divided into acute and chronic. So acute neutrophilia, which occurs between 4 to 5 hours after a pathologic stimulus, results from an increased flow of cells from the bone marrow to the peripheral blood. And what you can see are the band cells or band neutrophils and metamyelocytes. While chronic neutrophilia is a condition that follows acute neutrophilia. The bone marrow starts to throw out younger and younger cells, which what we call a shift to the left. Or shift to the left or left shift is an increase in the number of immature leukocytes in the peripheral blood, particularly the neutrophils band cells. A left shift can be due to release of bone marrow stores. Release of the marrow reserves usually occurs in response to acute inflammation, which is the most common cause of a left shift. So the most common cause is bacterial infections, particularly by gram-positive cocci. Other causes of neutrophilia are inflammation and tissue necrosis, metabolic disorders, neoplasms, acute hemorrhage or hemolysis, drugs, chronic myeloid leukemia, myeloproliferative neoplasms, rare inherited disorders, asplenia, and hyposplenism. Other features of reactive neutrophilia may include um, number one, a shift to the left in the peripheral blood differential white counts, which is an increase in the number of band neutrophils and occasional presence of more primitive cells such as metamyelocytes and myelocytes. A left shift is usually, but not always, accompanied by toxic change in neutrophils. So what are the toxic changes? These are uh, the presence of cytoplasmic toxic granulations, um, and Dolly bodies, and also the cytoplasmic vacuoles. So these three are actually the description of qualitative disorders, which we will talk about in the later part of the lecture. When immature white blood cells circulating in the peripheral blood with the presence of immature or nucleated red cells, it is called leukoerythroblastic reaction. A leukocyte reaction is an increase in white blood cell counts and immature white cells which can mimic leukemia but occurring in non-leukemic conditions. The reaction is actually due to an infection or another disease and is not a sign of cancer. So the causes of leukoerythroblastic reactions includes severe infections as in miliary tuberculosis, and metastatic neoplasms, for example, the carcinomas of lung, breast, prostate, GI, thyroid, kidney, and metastasized to bone marrow. Hematological disorders such as myelofibrosis, lymphoma, and myeloma, severe hemolysis, for example, thalassemia major, and also caused by storage disorders such as Gaucher's disease and Niemann-Pick disease. The leukoerythroblastic blood picture is characterized by the presence of circulating nucleated red blood cells and immature myeloid precursors, often with RBC anisopoikilocytosis, with the presence of many teardrop cells. The white blood cell counts can be normal or high. In most cases, this pattern is associated with anemia. Now, leukemia reaction. Leukemia reaction is an extreme neutrophilia with the white blood cell counts more than 30 times 10 to the power of 9 per liter. The leukemia reaction is a reactive and excessive leukocytosis, usually characterized by the presence of prominent band neutrophils and an increased count of more immature lineage of myeloids, such as metamyelocytes and myelocytes, and occasionally myeloblasts and promyelocytes. And the peripheral blood finding shows shift to the left. Leukemia reaction resembles chronic myeloid leukemia, CML, but we can differentiate leukemia reaction from CML in which in leukemia reactions there is no Philadelphia chromosomes. It is the condition is transient or temporary in leukemia reaction. Leukemia reaction has a high neutrophil alkaline phosphatase score, NAP score, and if an NAP score in CML is low, and no basophilia is seen in leukemia reaction. The causes of leukemia reaction includes a severe infection like Clostridium, tuberculosis, pertussis, and infectious mononucleosis, visceral larva migration, which leads to eosinophilia, tuberculosis that give rise to monocytosis, fungal infections also causes neutrophilia with monocytosis. Leukemia lymphocytosis is seen in tuberculosis, whooping cough, and infectious mononucleosis. intoxication, malignancy, severe hemorrhage, acute hemolysis, drugs like sulfadapsone, glucocorticoids, and use of granulocyte clonal limiting factors, diabetic ketoacidosis, ischemic colitis, and hepatic necrosis. In leukemia reaction, there is a significant increase of mature neutrophils in the peripheral blood, and a differential count showing neutrophilia with varying degree of immature lineage of myeloid cells. The platelet counts is normal, and you can see toxic granulations and Dolly bodies present in the cells. Now, a decrease below normal. Neutropenia is an absolute reduction in the number of circulating neutrophils below 1.8. Remember, the lower limit of normal neutrophils is 2.5. So neutropenia can be due to impaired production of bone marrow, shift from circulating pool to marginated pool, increased peripheral destruction, and a combination of these. When the absolute neutrophil level falls below 0.5, the patient is likely to have recurrent infections, and when the count falls to less than 0.2, the risks are very serious, particularly if there is also a functional defect. Causes of neutropenia includes congenital, such as Kotzman syndrome, is autosomal recessive disease, acquired in drug-induced neutropenia, cyclical neutropenia, which is regular recurring episodes of severe neutropenia. This can be familial and inherited with maturation arrest. Immune neutropenia, such as in HIV and SLE, infantile syndrome. Infections such as in typhoid, miliary tuberculosis, and viral hepatitis. So, we have finished the quantitative disorders. Next, the qualitative disorders of leukocytes. So, qualitative disorders of white blood cells are conditions associated with morphologic changes and or functional changes in one or more types of white blood cells. Qualitative disorders of the white blood cells can be divided into either acquired or inherited. The acquired qualitative disorders is morphologic. These are reactive, transient changes accompanying infectious states. They are the toxic granulations that results from impaired cytoplasmic maturation, Dolly inclusion bodies that represent rows of rough endoplasmic reticulum, and cytoplasmic vacuoles that indicates the phagocytosis. Toxic granulation is the term used to describe the presence of red-purple granules in the cytoplasm of the band neutrophils. The infection is the most frequent cause of toxic granulations. Dolly bodies are light blue-gray, oval, basophilic leukocyte inclusions located in the peripheral cytoplasmic of neutrophils. They are thought to be remnants of rough endoplasmic reticulum. The toxic vacuolation is the formation of vacuoles in the cytoplasm of neutrophils in response to severe infections or inflammatory conditions. So the inherited functional and or morphological abnormalities of qualitative disorders includes Pelger-Way anomaly, Alder-Riley anomaly, Shediac-Higashi anomaly, May-Hagelin anomaly, chronic granulomatous disease, myeloperoxidase deficiency, and leukocyte adhesion deficiency. Pelger-Way anomaly. This is a benign inherited autosomal dominant abnormality in which the neutrophil nucleus does not segment beyond the bilobular stage. However, the cells in Prager-Willi anomaly functions normally. Alder-Rayleigh anomaly. This is a rare autosomal recessive disorder associated with mucopolysaccharidosis. In this disorder, all leukocytes contain large purplish granules. This is not toxic granulation, but due to partially degraded protein carbohydrates in the cytoplasm. The cells, however, function normally. This is seen in Hüller's and Hunter syndrome, in which there is an incomplete breakdown of mucopolysaccharides. Shide-Higashi anomaly. This is a rare autosomal recessive disorder in which abnormal lysosomes are formed by the fusion of primary granules. They are seen as grayish-green inclusions or giant granules in the cytoplasm. The cells are ineffective in killing microorganisms, and affected individuals often die early in life from pyogenic infections. May-Hagelin anomaly. This is a rare autosomal dominant disorder in which the leukocytes contain large basophilic inclusions containing RNA that look similar to Dohle bodies. May-Hagelin anomaly can be differentiated from an infection because toxic granulation is not seen. The patients also have giant platelets that have a shortened survival time. Because of this, patients may have bleeding problems. Chronic granulomatous disease. This is a lethal sex-linked disorder affecting the function of neutrophils. The neutrophil can function in phagocytosis, but it cannot kill microorganisms because the cells have a defect in the respiratory burst oxidase system. Affected individuals have chronic infections with organisms that do not normally cause infections in normal individuals. Next one is myeloperoxidase deficiency. It's a benign autosomal recessive disorder characterized by a lack of myeloperoxidase in the neutrophils. Affected individuals may have occasional problems with candida infections, but usually they have no problems with infections because they have other mechanisms to kill microorganisms. The last one in the list is leukocyte addition deficiency. This is a rare autosomal recessive disorder characterized by the absence of leukocyte cell surface adhesion proteins. Because of the lack of the adhesion molecules, the leukocytes have functional defects in chemotaxis, phagocytosis, respiratory burst activation, and degranulation. Affected individuals have frequent bacterial and fungal infections, and mortality in childhood is high. Another morphological abnormalities include hypersegmented neutrophils, which occur in megaloblastic anemia. In hypersegmented neutrophils, the neutrophil functions is essentially normal. Another variation in neutrophils can be seen includes bar body. Bar body appears as a small drumstick-like projection on one of the lobes of some neutrophils in females. It is a rare chromosome disorders in which 3 or more X chromosomes are present. 2 to 3 bar bodies per neutrophils can be seen. Other benign white blood cell disorders. Eosinophilia, which is an increase in blood eosinophils above 0.5. Causes of eosinophilia includes allergic, such as atopic or drug sensitivity, infection, as in parasites, parasitic infections or recovery from infections, malignancies, as in Hodgkin's disease, non-Hodgkin's lymphoma, and myeloproliferative neoplasm. Skin disease such as psoriasis, dermatitis, and urticaria, and also graft versus host disease. Hypereosinophilic syndromes is a condition when the eosinophil count is more than 1.5 times 10 power of 9 per liter. Monocytosis. The causes of monocytosis include infections, as in TB and typhoid fever, malignancies in acute myeloid leukemia, myeloproliferative neoplasms, and non-Hodgkin's lymphoma, connective tissue disorders such as Crohn's disease, inherited abnormalities of neutrophils also seen in monocytes because they originate from a common stem cells. So you can see in monocytosis, chronic granulomatous disease, Shedad-Higashi, and Alder-Rayleigh anomaly. Basophilia, the most commonly associated with hypersensitivity reactions to drugs or food, it's inflammatory conditions in which, for example, ulcerative colitis also sometimes associated with basophilia. It's myeloproliferative disorders such as basophilia can be seen in chronic myeloid leukemia. Lymphocyte disorders is an acquired quantitative disorder, usually a self-limited. Both B and T lymphocytes are affected. The functions of these cells are normal, but the morphology may be heterogeneous. Lymphocytosis may be due to relative or absolutes. Relative is secondary to neutropenia, or absolutes, which is usually seen in viral infections. If absolute, it may or may not be accompanied by leukocytosis. Lymphocyte disorders. The non-malignant causes of lymphocytosis, for example, infections, the viral infections, infection mononucleosis, cytomegalovirus, rubella, hepatitis, chickenpox, and dengue. Bacterial infections such as pertussis, healing tuberculosis, and typhoid fever. Protozoal infections such as in toxoplasmosis, um, due to allergic drug reactions, hyperthyroidism, splenectomy, and serum sickness. So, one of the lymphocyte disorders is infectious mononucleosis. So, in infectious mononucleosis, lymphocytosis is accompanied by a leukocytosis. This is caused by Epstein-Barr virus infecting the B lymphocytes, in which the infected B cells are killed by cytotoxic T cells. So in the smear on the right, the reactive lymphocytes seen are the cytotoxic T cells. Another lymphocyte infections are the cytomegalovirus and Bordetella pertussis infection. In cytomegalovirus infections, there is a leukocytosis with absolute lymphocytosis. In Bordetella pertussis infection, there is leukocytosis with an absolute lymphocytosis. This is due to redistribution of T lymphocytes from the tissues to the circulation, in which the lymphocytes are small, normal appearing lymphocytes. Now, lymphocytic leukemia reaction. The peripheral smears on the right shows increased lymphocytes with younger lymphocytes. So, leukemia reactions may be seen in tuberculosis, chronic infections, and malignant tumors. Lymphocytopenia. This is a response to stress and to corticosteroids. For example, in immune deficiency disorders, for example, HIV and SLE, um, may occurs in after exposure to physical agents such as radiations, administration of cytotoxic drugs, and infectious hepatitis. Another lymphocyte disorders includes Wiskott-Aldrich syndrome, severe combined immunodeficiency system, DGeorge syndrome, X-linked agammaglobulinemia, and ataxia telangiectasia. Now, the microphage disorders. Microphage disorders includes lipid storage diseases in which the cells are unable to completely digest phagocytous materials, Gaucher's disease, which is a recessive autosomal disorder with a deficiency of glucocerebrosidase, um, Niemann-Pick disease, which is an autosomal recessive disorders, and Tay-Sachs and Sandoff diseases, which is also an autosomal recessive disorders. So this is my last slides. And don't forget to read the textbook, Essential Hematology. Please read chapter 7 and chapter 8. So that's the end of the lecture. Thank you.